Hi friends, today I will talk about ventricular tachycardia, which is a grave medical emergency. First is a disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. Ventricular tachycardia is a fast, abnormal heart rhythm that is more than 100 beats per minute that starts in the ventricle. It is a broad complex tachycardia and is defined as 3 or more consecutive beats at the rate of more than 100 beats per minute, and it can be life threatening. Ventricular tachycardia is usually of two types: non sustained ventricular tachycardia and sustained ventricular tachycardia. Non sustained ventricular tachycardia is the term used when it lasts less than 30 seconds and it stops its own and does not cause major instability. However, the sustained VT lasts more than 30 seconds. It causes hemodynamic instability in the form of low BP, shock, or even the cardiac arrest. And such patients they need urgent treatment. The ventricular tachycardia can be classified based on the morphology of the QRS complexes, monomorphic VT and polymorphic VT. Monomorphic VT is when we have same QRS complexes, uh, means their shape is same in all the beats, and this monomorphic VT usually occurs due to scar from the previous heart attack. Polymorphic VT, here the QRS shapes are very different. They are often seen in acute heart attack or electrolyte imbalances. There is another special type of VT, we call it as a Torsades pointis. It is a dangerous form of polymorphic VT which is linked to a long QT interval when the QT interval is more than 460 milliseconds in men and 480 milliseconds in women. Here, the ECG shows a twisting pattern of the QRS complexes, and it can quickly degenerate into ventricular fibrillation, and patient can have a cardiac arrest. In acute coronary syndrome, the VT is often polymorphic. In cardiomyopathy, VT is usually monomorphic, and it is caused by re-entry due to scarring. Accelerated idioventricular rhythm, it is a slow monomorphic VT, and it is seen in successful uh, reperfusion. Whenever there is uh, infarction, we thrombolize the patients, and we get this accelerated idioventricular rhythm, which is a which shows which gives us the evidence of successful reperfusion. VT is always dangerous. It can lead to sudden cardiac death, especially in patients with heart failure, previous heart attack, or cardiomyopathy. If untreated, it can deteriorate into ventricular fibrillation, causing the cardiac arrest. Early recognition and treatment of ventricular tachycardia can save the precious life of a human being. VT accounts for approximately 8% of the cases of wide complex tachycardia, and most common cause of ventricular tachycardia is underlying ischemic heart disease. VT in the presence of acute coronary syndrome is usually polymorphic, while monomorphic VT is a characteristic feature of myocardial scar-related re-entry. The other causes of ventricular tachycardia include ischemic or non-ischemic dilated cardiomyopathy, adult and congenital structural heart disease, inherited cardiac channelopathies, infiltrative cardiomyopathy, electrolyte imbalances like hypocalcemia, hypomagnesemia, drugs like cocaine, meth- methamphetamine, digitalis toxicity, infiltrative cardiomyopathy such as SLE, sarcoidosis, amyloidosis, rheumatoid arthritis, hemochromatosis, all these can cause ventricular tachycardia. VT is triggered by multiple factors. The most common triggering factor is myocardial ischemia, hypokalemia, hypomagnesemia, hypocalcemia, sepsis, and metabolic acidosis. There are certain inherited cardiac channelopathies which can also cause the ventricular tachycardia. They are more common in young individuals. The long QT syndrome, it is one of the most common inherited cardiac channelopathy and leads to Torsades pointis, which is a characteristic feature of long QT syndrome. The other inherited channelopathies responsible for VT are Brugada syndrome, catecholaminergic polymorphic ventricular tachycardia, short QT syndrome, malignant early repolarization syndrome, hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, and myocarditis are responsible for ventricular tachycardia and cardiac arrest and sudden cardiac death. Idiopathic ventricular tachycardia is uncommon and it is usually found in younger people with no evidence of any structural heart disease. The most common idiopathic ventricular tachycardia, they arise from the outflow tracts, mitral or tricuspid annulus fascicles of the left bundle branch. Idiopathic ventricular tachycardia is a benign and it responds very well to calcium channel blocker and has an excellent outcome after the catheter ablation. Major cause of sudden cardiac death is VT, and VT and VF, they are responsible for most sudden cardiac deaths. They are linked to coronary artery disease in about 15% of the cases. Means 15% of the coronary artery disease patients may have VT. VT is more common in men due to higher CAD rates, but the cases in women are also rising as the CAD rates are increasing in the women also. 5 to 10% of the heart attacks patient they develop VT within first few days. If the VT occurs after 2 days, the risk of death is very high. VT in children is rare but can occur due to inherited heart condition or structural heart disease. Idiopathic VT, that is without any cause, it is less common. It affects about 15 person in 1 lakh population, and more cases are diagnosed nowadays due to better awareness, and it can appear between the age of 20 to 70 with an average diagnosis at the age of 52 years. Coming to the pathophysiology of the VT, the mechanism of ventricular tachycardia, three main mechanisms are involved: re-entry, triggered activity, and enhanced automaticity. The re-entry is the most common form of VT, most common cause for VT. It is seen in patients with scarred heart tissues, that is post heart attack. It causes a loop of abnormal electrical signals which leads to continuous rapid heartbeats. It can progress to ventricular fibrillation and sudden cardiac death. Triggered activity, it occurs when abnormal electrical impulses they trigger the extra heartbeats. Early after depolarization is seen in long QT syndrome. Delayed after depolarization is seen in catecholaminergic VT, digoxin toxicity, or verapamil sensitive VT. Enhanced automaticity is also seen. Here the heart's pacemaker cells they fire too fast on their own and they play a role in catecholaminergic VT. Because of VT, the various hemodynamic consequences are seen. The first fast heart rate reduces the cardiac output, which leads to low blood pressure, poor blood flow to the brain, which leads to syncope, dizziness, or unconsciousness. Poor blood flow to the heart further worsens the coronary artery disease. Ventricular fibrillation and cardiac arrest can occur. Patient with normal heart may tolerate VT better, but prolonged VT can cause heart failure, tachycardia induced cardiomyopathy, and inherited heart conditions like long QT, Brugada syndrome. VT can suddenly worsen into VF and cardiac arrest even with a healthy heart. Coming to monomorphic ventricular tachycardia, the most common causes are structural heart disease, ischemic heart disease, dilated cardiomyopathy, hypertrophic obstructive cardiomyopathy, post-cardiac surgery scar. ECG features are regular, broad complex tachycardia, similar shape or uniform QRS complexes within each lead. Each QRS is identical except for the fusion or the capture beats. Other features of monomorphic VTs are rate is usually more than 100 beats per minute. QRS complexes are broad, that is more than 120 milliseconds, and they are usually more than 160 millisecond. Extreme axis deviation, that is northwest axis, is seen. QRS positive in AVR and negative in 1N AVL. Sorry, AVF. AV dissociation, P and QRS complexes at different states is also seen. Patient can have captured beats, means sinoatrial node transiently captures the ventricles, the QRS complexes of the normal duration. Fusion beats occur when a sinus and the ventricular beats they coincide to produce a hybrid complex of intermediate morphology. Positive or negative concordance is also seen in leads V1 to V6 show entirely positive R wave or entirely negative QS complexes with no RS complexes seen. RSR, that is RBB complexes with a taller left rabbit ear, which is most specific finding in favor of VT. This is in contrast to right bundle branch block where the right rabbit ear is taller. The Burgada criteria is to differentiate between the VT and SVT. If the answer to any of these is yes, then it is VT. Means Brugada criteria is used to differentiate between ventricular tachycardia and the supraventricular tachycardia. If answer to any of below mentioned is yes, then it is VT. Means absence of RS complexes in any lead, then it is VT. RS complex in any lead with RS interval more than 100 millisecond, it is VT. When there is AV dissociation, it is VT. The morphological criteria present for VT, present from V1 to V6, it is also VT. Coming to polymorphic VT or Torsades pointis. Torsades pointis is a specific form of PVT, that is polymorphic VT with QT prolongation. The characteristic morphology is QRS complexes they twist around the isoelectric line and due to multiple ventricular foci results in QRS complexes which vary in amplitude, axis and duration. The causes are myocardial ischemia or the infarction, electrolyte imbalances which leads to QT prolongation like hypokalemia, hypomagnesemia, hypocalcemia, even hyperkalemia also. Patients with hypoxia and acidosis, they can have polymorphic VT or TDP. The drugs like antipsychotic drugs, tricyclic antidepressants, amiodarone, chloroquine, azithromycin, fluoroquinolones, they also cause polymorphic VT. Patients with VT, we have to be very particular while taking the history. The symptoms of the VT they vary based on the age, heart condition, and the underlying cause. The common symptoms the patient presents is palpitation, that is fast, irregular heartbeat, shortness of breath, chest pain, dizziness or fainting, cardiac arrest or sudden death in severe cases, idiopathic ventricular tachycardia where there no cause is there. They are often triggered by exercise or stress and they usually present as a palpitation. In patients with coronary artery disease, VT patient may have chest pain, shortness of breath, syncope, or cardiac arrest. In patients with VT in heart failure, they will be poorly tolerated, leading to severe shortness of breath, syncope, even sudden death. VT from genetic condition like channelopathy can cause sudden fainting or cardiac arrest, requiring a detailed family history of at least 3 generations. Patients with VT on physical examination will have low BP, fast heart rate. So on physical examination, patient will have low blood pressure, fast heart rate, raised JBP, Canon A waves, swelling of the legs or the lungs means patient will have crepitations. On precordial examination may reveal signs of heart disease like heart murmur or enlarged heart. We have to look for side effects of antiarrhythmic drugs like amiodarone. So, how do we evaluate ventricular tachycardia? History and physical examination play an important role. We have to take a detailed history of risk factor, for example, heart disease, previous palpitation, fainting, or VT episode. Ask about the family history of inherited heart condition at least 3 generations if channelopathy is suspected. Physical examination can help identifying the underlying heart disease, and it helps in guiding the management. The ECG, 12 lead ECG during VT if possible, and in sinus rhythm to detect causes like heart attack, long QT syndrome, hypertrophic cardiomyopathy, Brugada syndrome, rhythmogenic right ventricular cardiomyopathy. We can do treadmill test for VT triggered by exercise or suspected ischemic heart disease. Patients with ambulatory ECG, that is Holter, is done if VT is not caught on any single ECG. Implantable loop recorder for rare but suspected VT episodes can be done. We can do echocardiography and imaging. Echocardiography is done to evaluate the heart structure, function, diagnostic hypertrophic cardiomyopathy, dilated cardiomyopathy, and ARVC. Cardiac MRI CT scan can detect myocardial scarring, ARVC, myocarditis, CT coronary angiography for young patients with unexplained cardiac arrest. Invasive evaluation include coronary angiography for VT linked to heart attack to check for blocked arteries. Electrophysiological studies no longer routinely done, but they are used in selected cases to assess the sudden death risk. Endomyocardial biopsy is done for patients uh, who, who are suspected for myocarditis or infiltrative cardiomyopathy when other non-invasive tests are unclear. Genetic testing is not routinely needed, but it is recommended for suspected inherited channelopathies, asymptomatic family members of the patients with genetic heart conditions, for example, long QT syndrome or ARVC. Other important tests like electrolytes, sodium, potassium, calcium, magnesium are very helpful for diagnosing and managing BT. High sensitive troponin is helpful for checking the heart attacks. Natriuretic peptides BNP and T-proBNP can predict the heart failure risk in VT patients. Coming to the management of the ventricular tachycardia, for sustained monomorphic ventricular tachycardia, if the patient is hemodynamically unstable, which is common in polymorphic VT than monomorphic VT, if patient is in monomorphic VT, synchronized cardioversion, that is with 200 joule is given. If polymorphic VT is there, we give unsynchronized DC shock 200 joule, as the monitor may not recognize the synchronization. If there is no pulse, then we have to treat it as a pulseless ventricular fibrillation, and we have to start the CPR simultaneously. If the patient is hemodynamically stable with normal left ventricular function, we can start IV amiodarone, but this is contraindicated in patients with hypotension. The first dose is 150 mg bolus over 10 minutes. Repeat if needed, followed by infusion 1 mg per minute for first 6 hours, then 0.5 mg per minute for 18 hours. How do we prepare the infusion? We just one vial contains 150 mg of amiodarone. We take 6 vials, that is 900 mg, dissolve in 450 ml of normal saline, and this solution is 2 mg per ml. It is to be infused as 30 ml per hour for first 6 hours, then followed by 15 ml per hour for 18 hours. Same dose can be given in 5% dextrose except in diabetic patients. Thereafter, we can start per oral amiodarone as 400 mg 12 hourly for first 2 weeks, then 300 to 400 milligram daily, and reduce doses to 200 milligram daily if possible. IV lidocaine 1 to 1.5 milligram per kg, typically 75 to 100 milligram at 25 to 50 milligram per minute. Repeat 0.5 to 75 milligram every 5 to 10 minutes if needed, especially in acute MI. IV beta blocker like IV sotalol, metoprolol, IV procainamide, they can also be used. If the patient is hemodynamically unstable and has abnormal LV function, then we can give synchronized cardioversion 200 joule as needed with sedation. Polymorphic VT, if stable hemodynamically, we have to look for QT interval. If QT is prolonged, look for cause for such as hypokalemia, hypomagnesemia. drug toxicity, and we have to correct it. For Torsades, point is QT, IV magnesium sulfate 2 gram IV stat can be given. In cases of recurrences, isoproterenol infusion up to 20 microgram per minute to increase thereafter to 120 increase thereafter the heart rate of more than 120 minute per minute. If normal QT is there, we have to look for underlying cardiac disease and treat the cause. For prevention of future arrhythmias, especially in the long QT syndrome, beta blockers like metoprolol, carvedilol, bisoprolol, amiodarone can be given. Device therapy or electrophysiological interventions are required. In some cases, ICD is required in all survivors of cardiac arrest with ventricular fibrillation or unstable VTs due to irreversible cause or structural heart disease. Catheter-based radiofrequency ablation in structurally normal heart is associated with VT. The complications of the ventricular tachycardia depends on the cause. Idiopathic ventricular tachycardia, that is without any heart disease, can lead to tachycardia-induced cardiomyopathy and heart failure, especially in patients with frequent or prolonged episodes and those with risk factor like alcohol use. Inherited VT and scar-related VT can cause cardiac arrest, sudden cardiac death. However, early detection and the use of implantable cardioverter defibrillator can reduce these risks. Beta blockers can help lower the risk of sudden cardiac death in patients with cardiac channelopathies and ischemic cardiomyopathy. In summary, for acute management, if the patient comes with cardiac arrest, we have to follow the ACLS protocol for resuscitation. If the patient is unstable VT, immediate electrocardioversion. If VT recurs, we can use IV amiodarone. VT due to heart attack, perform the coronary angiography and revascularization. VT storm, that is more than 3 VT episodes in 24 hours, treat with antiarrhythmic drugs, beta blockers, cardioversion. Severe cases, they may need mechanical support or ablation. Stable VT with structural heart disease, IV procainamide, amiodarone, sotalol, lidocaine can be used if other drugs are not available. Idiopathic VT treat with beta blockers. Long-term management for heart disease and VT risk, implantable cardiovert defibrillator, that is ICD, for patients with prior VT, cardiac arrest or weak heart function. Beta blockers, they reduce the VT episode. If VT recurs, we can use amiodarone or sotalol. Catheter ablation for drug resistant VT can be used. Special cases like long QT syndrome and CPVT, beta blockers are the first line. ICD for high risk cases. Brugada, hypertrophic cardiomyopathy, ICD placement if VT causes cardiac arrest. Idiopathic VT, most respond well to beta blockers or calcium channel blockers, and catheter ablation can be needed. Differential diagnosis of VT is supraventricular tachycardia with bundle branch block, SVT with pre-excitation, that is WPW syndrome, antidromic AV reentrant tachycardia, pacemaker mediated tachycardia, metabolic abnormalities like electrolyte disturbances, acidosis. How do we differentiate VT from other causes? We have to take the detailed history and clinical examination. We have to do ECG, specific ECG algorithms. They help to distinguish VT from SVT with aberrancy. ECG features may also help identify the exact origin of the VT and differentiating the idiopathic VT from other types. Martin H. Fisher has said, observation, reason, human understanding, courage, all these makes a good physician. Thank you. Keep learning.